Welcome to the webinar, everybody. Going to get started here shortly. Once again, welcome to the webinar, everybody. Get started here in just a little bit. Just going to wait for a few more people to come in. Welcome, everyone. We'll get started here in just a second. Okay, I think we'll go ahead and get things going here. Hi, everybody. Welcome to the webinar, Diagnostic Hand Ultrasound Part 4, Advanced Hand. My name is Chris Pennell, and I'll be moderating today's webinar. This is the final webinar in our 4-part series on the hand. And if you missed any of the first parts of the webinar series, you can watch them on our webinars page on sonosite.com/behind-the-scan-webinar, or you can check them out on the Sonosite Institute as well. And if you go ahead and scan that QR code on the screen right there, that'll take you right to our webinars page. All of our other previous webinars are also available there and on the Sonosite Institute, so feel free to take a look at our archives for more educational material. Before we begin, please be advised all attendees are muted. We'll be conducting a Q&A session at the end of the presentation, so feel free to send those questions in while the presentation is going, and I'll make sure that we get to them at the Q&A session at the end. If you're on the Zoom stream, you can type your questions into the Q&A box in the toolbar located at the bottom or the side of your screen. And for our viewers on YouTube and LinkedIn, you can enter your questions in the chat box, and we'll make sure to get those sent over. This webinar will be recorded and archived for future reference on our webinars page and on the Sonosite Institute. So to get started, I'll introduce our presenter, Daniel Shelton. Daniel is the Director of Musculoskeletal Market Development for Fujifilm Sonosite. Daniel has spent 21 years as a dedicated musculoskeletal sonographer, and 16 of those years have been here at Sonosite. He now leads musculoskeletal market development, where he works to spread the word about the benefits of point-of-care ultrasound. And with that, I'll hand it over to Daniel to get started.
Okay, Chris, thank you for that introduction. We'll go ahead and get started. I do want to say up front, this is going to come really fast. This is the advanced ultrasound of the hand, and we're going to cover a lot of anatomy. And I'm assuming that you've been through the other parts of the webinar, so some of the content will just be briefly discussed because we've already gone into it in other portions. And the live scan was pre-recorded and cut and diced to avoid any unnecessary time, basically switching transducers or long gaps between audio, things like that have all been trimmed out to maximize content because we have a lot to go through. So I apologize for something that may seem fast, but this is mostly a reference for you also, and the full content will be put on the Sonosite Learning Institute in the future. Okay, we'll get started. Now we're going to cover the extensor hood, nail bed, collateral ligaments, and the pulleys. Starting with the extensor hood complex, we'll get into the sagittal band, the extensor tendon, and the lumbrical and interossei relationship to the lateral bands. Looking at the side of the second digit, we can see the extensor tendon going right over the joint, the MCP joint. So we have the MCP, PIP, and further down the line is the DIP. We've already talked about the joint capsule, so we won't go into a lot of detailed anatomy on that like the arthritic webinar, but I do want to show you the relationship where the joint capsule is underneath the sagittal band. So the joint capsule goes underneath sagittal band. We can see the sagittal band coming up to envelop the extensor tendons. We can also see these other contributing structures to the dorsal extensor hood complex, which is this connective tissue umbrella that sets off to the sides of the joint, mostly at first, and then it contributes fibers up and across this entire extensor mechanism. Dorsal aspect of the joint here, we've got it dissected where we can see collaterals away from kind of a window into the joint. We can see that homologue and the joint capsule folding back proximally and redundantly. We can see the lateral bands. Those are the contributing fibers between the lumbrical and the dorsal interossei, or depending on the joint that you're on. It could also be the palmar interosseous. But on the second digit, that would be strictly dorsal interosseous and lumbrical. And then we have the extensor hood complex, which is that band of fibers. Here it is just dorsally. And then we'll skip the junctura tendinum, but those are those little connections between the extensor tendons back here on the top side of the palm. Mid-sagittal slice through the MCP joint we covered in the arthritic hand webinar a little bit. So we've got that joint capsule starting at the metacarpal notch, good landmark, folds back redundantly, looks like a suprapatellar recess in the knee, comes back and folds, and then dives at the proximal phalanx. Here's where we can see the sagittal bands. So we can see a superficial sagittal band and a deep sagittal band. You can flex and extend the tendon to see it all move together away from the joint capsule. A little more distally at the PIP joint level, we've got proximal phalanx, middle phalanx, and then you're going to focus on the central slip of the extensor tendon. It's going to look really thin mid-shaft of the proximal phalanx, and then we're going to see it look really thick because we have this whole host of contributing fibers from the lumbrical area and from the dorsal interosseous, where it contributes fibers very heavily right across here, kind of forming a network of tendon. Here's what that central slip looks like. It does look thicker because of all these contributing fibers coming in from the sides. We'll go to the live demo quickly.
I tend to show people how to start this scan on when there's a single tendon over the joint and not these variations with two tendons over the joints. Finger is hanging down below so that I'm in control of my pressure into the gel heap. Slowly rest the transducer into the gel. To optimize this image, I'll begin by decreasing my depth. Am I on the distal metacarpal or the proximal phalanx? There's a couple ways to tell that. So I can see that metacarpal notch that was discussed in the arthritic hand segment. I can see these dips on the side, which have a unique footprint for collateral ligaments. I can go distal and drop into the joint. So there I'm between bones, and then go distal a little bit more. And that shows me that I'm at the proximal phalanx. So it's always good to get oriented with the bones. So here's proximal phalanx, joint as I go proximally, and then distal metacarpal head. The distal metacarpal head also has this articular hyaline cartilage, good bony landmark. It's incompressible. So the layers on top of this, we can see her skin. We can see the extensor tendon as this oval, and I can tilt and use anisotropic artifact to my advantage to determine what's tendon and what's not. But for the most part, it's easy to just scan proximal, distal, and see the persistent oval that sits here. And as I go proximally, you'll see these little shadows start to form on each side right there. So these are the shadow of the the sagittal band. We have two parts of the sagittal band. There's a superficial sagittal band that goes over the extensor tendon, and there's a deep sagittal band that goes below the extensor tendon and kind of act like another sling or pulley on the dorsal part of the hand. Now that shadow on both sides does extend over the proximal phalanx a bit, but the sagittal band itself really stops at the joint. It does wrap around if you chase that shadow on the second digit, because we can curve all the way around. You can chase that shadow down to the intermetacarpal ligament level, where it will start to blend and taper in with the pulley mechanism on the volar hand and the volar plate. On either side of the joint, we have neurovascular structures. So we have the superficial digital nerves and vessels. We could confirm that with color. So I'll hit the C button for color, go find a vessel, nerve, vessel over here. And then same thing repeats in this interdigital space here. Let's go long axis. I'm going to lay down a nice bead of gel right across where I know the dorsal hood goes towards the middle portion of the proximal phalanx. And then you'll see me use this other thumb as kind of a windshield wiper to elongate the structures to get a maximum long axis. Distal metacarpal head, proximal phalanx. Again, we have extensor tendon, and in the arthritic hand webinar, we went over the joint capsule anatomy, how it dives into this metacarpal notch. So we have metacarpal notch, and you follow that back. There's a redundant fold of the joint recess where it folds here and climbs up under the extensor tendon. We have that fat pad or the homolog that sits in the joint, that little triangular wedge. And then the joint capsule terminates right here on the proximal edge of the proximal phalanx. Extensor tendon is not all of this thick structure here. So I'm going to have our model just twitch her finger. There we go. Or you can manually do it or passively do it. And you can see the stuff that's moving there. So that's not all extensor tendon. If we were to look really, really close, I could see that I have long axis fibers here and short axis fibers here. But what might just look like a homogeneous structure, like any other fat pad, can be confirmed in the other plane. Remember, we went and saw a deep sagittal band, but the deep sagittal band was in long axis this way, split the screen. So I'm going to use the dual feature, and then I'm just going to rotate the probe. Left side will be radial there. And we can see that long axis, deep sagittal band underneath the extensor tendon. So extensor tendon, long axis, deep sagittal band, and metacarpal notch. And you can see that reflected over here. So here we have a long axis extensor tendon, short axis, deep sagittal band, and then the metacarpal notch. So we're at the same level. So screen right is taking about this slice here, because I can see the metacarpal notch right here. So just to clarify, these homogeneous structures on top of the metacarpal notch are not related to the joint, but the joint starts here, right at the tip of the arrow. The joint capsule can make the joint capsule move. In all of MSK ultrasound, make sure you're making it move to distinguish these structures. So you can see that deep sagittal band does try to move with the extensor tendon. That's another indicator it's not a part of that joint line. I'll just switch over to the ultra high frequency. This is the ultra high frequency 46 to 20. So we have our metacarpal notch. Here's the joint. Here's that homolog. Okay, so this is the cross-sectional deep sagittal band, and this is the long axis extensor tendon. So I'm using a little bit of anisotropy here, and we can see the angle artifact that's cast off that superficial sagittal band right here. Again, make it move. And I'm just going to drag the skin back and forth. I can start seeing the layers between the skin and the extensor tendon complex that's happening here show themselves a little bit. So let's trace that distally now that we've kind of vetted out our superficial and deep sagittal bands, our metacarpal notch and joint capsule, which is redundantly folding back here at 46 megahertz. We can see a normal joint recess on an MCP joint, which is not always the case with lower frequencies. It will be averaged out. So there we can see I'm just causing that joint capsule to move. Let's go short axis to appreciate the sagittal band anatomy. We've got extensor tendon here, superficial sagittal band, casting a really hard shadow because of the fine, very thin nature of this ultrasound beam being 46 megahertz. Anisotropy is a little bit more prevalent with this probe. Tilt the transducer and aim down the side. So we have extensor tendon, deep sagittal band, shadow of that extensor tendon coming in with the deep and superficial sagittal band. And then you can trace the superficial sagittal band down here. And then you can see this bump off the metacarpal head. And we'll segue into the collateral ligaments here later. But it reminds me of a lateral epicondyle of the elbow, if you get it in the right plane. And the attachment of the collateral ligament looks a lot like the common extensor tendon when you get it into its long axis. But I do want you to know where the collateral ligaments begin and end, because we're going to do a dynamic maneuver to show where sagittal band begins and ends. Sagittal band, superficial and deep. And then we can see collateral ligament anatomy starts here. Somewhere in between here is the joint capsule. It's really thin, it's normal, and it's just a potential space at this point. But to delineate potential space, just like in a subacromial bursa in the shoulder, I'm going to spread her fingers a little bit. You just want to make it move to delineate the space. So I'm going to grab her finger and just wiggle back and forth. And I can see the layers underneath that deep sagittal band moving, and that's revealing this layer right here is the joint capsule, right where my arrow is. And if I were to go distal to that, I could see joint capsule sitting on cartilage. So here's cartilage, and I can see the joint capsule move this way. So if I follow the extensor tendon distally into the joint right here, so the joint, I don't see any bones here. I just see extensor tendon. I'm going to go distal, distal, distal. Now I'm at the proximal phalanx. The extensor tendon is starting to flatten out, and the central slip will attach right here on the proximal edge of the middle phalanx. And on each side, you see vessels, neurovascular structures, easy to compress. But you can follow that extensor tendon, which is this oval. Let's go more shallow. There we go. Really, really nice. Nice flat extensor tendon. So distal, proximal, and then move into another zone. Distal, proximal, and just pick one structure and then just kind of vet it out with the beam. Because here you can even see the extensor tendon as it reaches the central slip area, the PIP. we're going to follow a few fibers where it splits. So it'll divide like we saw in the anatomy diagram. One part goes to central slip proximal of the middle phalanx, and then it divides into two pieces and goes around the knuckle and continues on to the sides of the DIP. So we'll follow those with ultra high frequency. So here the tendon is more centralized. I can see the tendon here, and then watch on each side, you'll see these round ovals start to form that are more anisotropic if you tilt the probe back forth, but that's what this oval is here. So we'll just keep following this oval, it will go around the PIP, joins up with lumbricals and a bit of the interossei tendons, and eventually come all the way down to the DIP. So if the layers are looking like they're just kind of getting muddied together, pick one side of the joint, not central, or not joint, but the finger. Don't scan in the middle of the finger. Pick a side, lean the probe into that side because we have to stay perpendicular to it, and then just find one echo on the screen and go proximal, distal before you move on. And definitely don't hold the probe still for these exams. You got to really move the transducer, so make it move. But we're just following these teeny tiny tendons to their eventual insertion on the DIP. What we're seeing here is the beginning of the nail. So we're at the nail bed, joint of DIP, and that's where we get that triangular ligament in the middle of the DIP area. These two tendons come together, and we've got that triangular ligament, which is just a little bit of a fascia between the tendons that attach at the DIP level. So this right here where my arrow is triangular ligament. It's in cross section, or it's traveling cross sectionally across the joint of the DIP, or proximal to the DIP. And then on each side are the tendons for that go to the eventual insertions. So we'll just look at the insertion of the DIP really quick. And a bit of the nail bed since we're in the area. So we'll just kind of combine those scanning topics real quick. So we've got the kind of central portion of the common extensor tendon right here. So extensor digitorum attaching here. But remember, on each side, we've got those slips coming in from the oblique side of the finger. So we can see a distinct tendon here on the side, tracking all the way down. So that's lumbrical, that's dorsal interossei, kind of combined to create that pathway for the extensor tendon to combine all those fibers. So you'll see a really strong tendon appearance and long axis here, even though I'm on the side of the knuckle. And you can confirm that it goes all the way to the tip just by moving the DIP. So I'm just pushing the DIP down, and I can trace which tendon I'm following. And you'll just have much better luck going down the side walls of these fingers, not dorsally. You can go extreme dorsal right there and get some of those fibers to move, but they're really thin, and a lot of them attach right here on the PIP. So we're not catching all of the extensor fibers, but if you go to the side of the PIP, you'll catch those kind of traveler tendons that go down and all work together to insert at the DIP level.
Getting right into where we left off on the dorsal PIP joint, basically. So we're going to cover more anatomy of the dorsal PIP and then combine that with the nail bed anatomy. So they go along so well together. My favorite atlas for this is the surgical anatomy of the hand, if you want to know where I got this particular illustration, and the following two illustrations coming up. So you can see the extensor tendon is a little bit complex as we approach the DIP joint. You can see that triangular ligament here going between the two heads of the lateral bands. Those lateral bands come on to insert seemingly what would be on the base of the distal phalanx right here. But there are other fibers that keep going that we can see at ultra high frequency to come across the nail plate here at the base of the cuticle, and that's called the nail halter. And so we can see that there's a nice group of bands going all the way across the nail bed, and that is something that's very well appreciated, especially at ultra high frequency. We'll talk about the nail plate as well. I apologize in advance. These two illustrations are facing each other. So left side of the left screen is proximal, and the right side of the illustration over here is proximal on the right. So distal's in the middle of the screen, I guess you could say. But we can really appreciate these layers of anatomy where we can see the nail plate come down to the nail root, forming right at this dorsal matrix area where everything kind of granulates and begins and starts growing our nail. And then you can see the connective tissue fibers here from that nail halter that we talked about. So we can see the extensor tendon insert, more commonly, easier to appreciate on most transducers, but then on ultra high frequency, which we're focusing on here, you can see that continuation of fibers that do come up off the DIP extensor tendon to the nail bed, and not nail bed necessarily, but to the base root of the nail plate. Here's a cadaver cross section, also out of the surgical anatomy of the hand atlas here, where you can really appreciate that layer coming across to the nail root. And then it just does a good job at distinguishing where the cuticle is, where the matrix is, where the nail halter is, and then the nail bed. All right, let's go look at it.
For the nail bed exam, we'll be using the 15-4 workhorse transducer again, because it's the transducer just about everybody has. And then we'll switch over to the 46-20 large gel heap right across the nail. So let's do that really quick so we can see the whole thing. Even extend the gel a little bit past the nail. So we just kind of lay down a nice bead of gel there, hanging my finger underneath the transducer and bracing that onto her finger first. I've got 2 fingers here, and that's going to allow me to stay very, very steady and level. So 2 fingers kind of bracing down into that gel heap. That helps me descend my transducer into the gel. So superficially, I need to optimize this picture. The image is kind of focusing to the middle of the screen. So to make this image look better, I need to decrease my depth. So we'll go as shallow as possible since we're scanning a nail bed. You'll see things sharpen up really nice. Middle phalanx distally, distal phalanx proximally. We've got the DIP joint, and then we ended the extensor tendon exam with that extensor tendon climbing over the DIP. So we see the joint and the recess here. And then I can see the tendon somewhat attaching here a bit, but we know from the slides there's a bit more of anatomy to look at here. So there's fibers that jump from the extensor to the nail root, which we'll be evaluating at 46 megahertz a little bit better, but I want to see what I can see. So it's important if you're looking at this nail bed to make sure your fingernail image is as reflective as possible. What do I mean by that? If I tilt the probe and I see these fuzzy echoes, I'm not 90 degrees to the nail. And if I don't see a sharp point right here inside the nail matrix area, or the halter, which is a cross-sectional ligament holding that nail in place. So we're seeing what look like homogeneous fibers around the nail root. And what it is cross-sectional fibers going across the whole distal phalanx, wrapping around to the collaterals, basically, acting like another pulley mechanism or hood, keeping the nail situated with this extensor tendon. And then we have the nail matrix down here, nail plate, nail bed. And I do find that if you add even a little taller gel standoff, you can control the focus of the beam a little bit more with just the depth that you let the transducer go into the gel. Not to mention, the more gel you have, the more it enhances the sound wave. So you're using a bit of posterior acoustic enhancement to create a scanning window that highlights anatomy. So the gel is enhancing the sound waves, making it look really, really nice. But that's your nail root right there, nice and sharp. It is a highly vascularized area, which we covered slightly in the arthritic hand webinar, but I'll hit color just to demonstrate that. And I'll probably have to drop my scale a bit and turn the gain up. So drop the scale, turn the gain, and we should start seeing these nice little vessels in the area. You could switch over to power Doppler, CPD. And what the difference is between the colorized Doppler and power Doppler is the directional or DCPD Doppler basically is using the computing power of the ultrasound machine to assign velocity, direction, and that takes a lot more computer processing. But if you switch over to power, it only uses the amplitudes of a signal. It is a bit more sensitive to motion artifact, but because it's not using the information necessary to assign velocity and direction, it does allow the ultrasound machine to process a bit more low flow areas, since we're just concerned with if there's blood flow there or not. So there we can see her nail. We see a little bit of mirror image artifact happening here. So that's kind of fun to point out. So there's a vessel here, and it's climbing its way over to the nail root. And then we have a hard specular reflector of the distal phalanx, or the middle phalanx distally. And what's happening here is the Doppler effect is catching these echoes, and we're catching reverberation under the bone. And when we see that reverberation under the bone with something that's moving with reverberation, it also assigns it a Doppler shift, but it will be in the exact location opposite to the bone. So we're seeing a perfect reflection upside down of that vessel underneath the cortex. So we're not seeing flow under the cortex. That's not real flow. That's mirror image artifact. It's a pretty cool property of a Doppler exam to be aware of, or a color exam. You don't always get it. It's hard to reproduce, but one that it's really easy to practice on if you get a chance to try that artifact out is the dorsalis pedis, and your ankle is a very easy one to create a mirror image artifact. Switching over to our 46 megahertz transducer. This is called the UHF 46. And it is a lot of fun to scan with. So again, I've got cord management, cable management here. I have wrapped this cord right around my hand like this. And what that does, again, is it allows me to be a little bit more dexterous with my hands, and I'm not fighting the weight of the cord off the end of the table or something like that. Using that gel standoff again, we'll start with a fresh bead of gel. And I've got my fingers under here like stilts. So I'm going to use them to control that descent into the gel on each side of the probe. And here we can see a very clean image of that nail root and the nail plate. Again, you want to be 90 degrees to the surface where you won't catch those echoes reflecting back really nice, but really, really nice nail root. And then it's not so hypoechoic anymore, but we do have a set of fibers here that we're looking at cross-sectionally that encompass that nail root. Okay, and that's called the nail halter. And that's that section of ligaments that goes around and wraps almost like an extensor hood and attaches this set of fibers to the extensor tendon here. So we've got this kind of really, really fine ligament layer jumping from the extensor tendon over to this nail root. Let me go short axis. So left side of the screen will be radial. Here is the skin. So we have that nail root following it down, and then here's that DIP joint. And I'll put a bead of gel just across the DIP level so we can see that triangular ligament. So DIP, there you go. There's that face I was talking about. I find that in just about everybody. But here's long axis fibers of the triangular ligament right here. And if we were long axis to the joint, we'd be looking at kind of short axis fibers. And that the true extensor tendon terminates. See these ovals on the side? Watch me squish the subcutaneous fat a little bit. You can see these ovals that show up on each side of the joint. That's a cross section of the extensor tendon complex from the lumbricals and the dorsal interossei of what eventually terminates with those extensor tendons after they pass the central slip and come down to the distal phalanx. So these ovals on the side are your real tendons. And this guy in the middle is not necessarily extensor tendon, but the triangular ligament that does jump across the joint gap and inserts on the proximal end of the distal phalanx. The nail and make them move, because this is ultrasound, we're going to make it move. Then you can follow those fibers right there, right where my arrow is. So that was lucky. And you can see how far on the side of the phalanx I am. I'm not mid-sagittal to the phalanx. And I'm seeing those fibers move real nice. Now we'll look at the color with the UHF and just see what we can see. I've got power Doppler already selected. I want to open my box just a bit tall. Got a little bit of noise at the top of the screen. I'm going to bump my scale up a touch, clean that up, and we start to see really nice flow. And even cross-sectionally, left side of the screen, I'll make radial. So I've got the nail going in. Here we go. You can see what looks like two semilunar echoes. Got skin and cuticle, nail going to root, nail matrix. We'll hit color to see what we see. And it's also awesome to go compare to other joints too. So if you're expecting things to be systematic or just in one area, you've got that option. These are very tiny vessels. I'll go through my scales just to make sure we're seeing all the flow we need to see. So that's the lowest scale. It's going to let in the most noise. And then I've got a wall filter of medium. So I'm going to go down to low wall filter, turn my gain down just a touch. There we go. Earlier I had a median wall filter and I probably would have seen more vessels and long axis like we're seeing here. So there's that nail matrix just around that root. I'll go long axis to that. What I mean when I talk about color scale. So color scale is a lot like shutter speed in photography or cinema photography, where you can have your scale set in properly when you're looking for something that's moving. So imagine a wagon wheel turning in the picture frame like an old classic Western film, and the shutter speed is clicking at its standard rate. Let's just say it's 60 hertz. So it's taking a flash once every 60th. And if the wheel that's moving on the screen is moving at the same rate as the flash from the shutter of the camera, it'll look like the wheel is standing still. And that's why you see those old films when the wagon is chasing across the prairie and it looks like the wheels are standing still. That's because the revolution of the wheel is catching up to the shutter frame of the camera. And that same thing can happen here with color. So that's when you want to go through your scales, because everybody has a different velocity, everybody has different blood pressure, everybody has different just properties to their blood. So that can also affect things like temperature in the room. Can also make a big difference when you're scanning things with low flow.
Okay, now time for the ligaments of the hand. Focusing on the side of that second MCP joint, just because it's easier to see and study. We're going to walk through the primary and the accessory. Now, primary and accessory, think P over here. Accessory and primary, think anterior and posterior. So if you're in an anatomical position, this is the posterior side of the hand, and the palmar side is the anterior side of the hand. So the primary ligament stays very posterior, and the accessory heads anterior. So that's one way to remember it. The accessory does eventually contribute to the fibers of the palmar plate, just as a reference for you, and the pulley. Here it is in cross section at the distal part of the MCP joint. This is the distal metacarpal head here. We've got the extensor tendon. We've got illustration of the sagittal band here, superficial sagittal band, deep sagittal band, and their fibers that come out between the interdigital spaces. Below that, we have a joint capsule. Below that, we have a primary collateral ligament and then an accessory collateral ligament that contributes to this network of the palmar plate. Here it is on the first digit. So this is the collateral ligament to the thumb. Again, think anterior and posterior. The anatomy repeats here. Then we have the extensor pollicis that's going to come into play and attach to this aponeurosis that comes from the palm of the hand. Remember the adductor, the big landmark in the hand, the transversely oriented muscle that eventually heads towards the thumb. We're going to take its superficial fibers and then see them drape out like an umbrella over the MCP joint of the first digit. And then what we're going to do is wiggle the thumb and see it differentiate itself. So why does that matter? So if you end up with a tear of the ulnar collateral ligament of the thumb and it protrudes through this network of fibers, then surgical intervention is required. You have what's called a Stenner's lesion. If this ligament ruptures and the tear stays beneath these fibers, then you've got an isolated ulnar collateral ligament and probably a few more options of treatment. Here's the dynamic maneuver and what you should see. So we've got our distal metacarpal and our proximal phalanx, and then you can see the aponeurosis moving here. Here's what that looks like, and we'll do more in the live demo, but use this as a reference. And then also use this slide as a reference for your future learning, but I'll cruise through the anatomy pretty quickly here. Again, proximal or distal metacarpal head. Here's that kind of epicondyle looking origin of the primary collateral ligament. And then here we can see moving back and forth the extensor pollicis longus relationship to the adductor aponeurosis that's moving here. Let's go look at it.
I'll start out with collateral ligament anatomy here on just the second MCP because we can follow it around, and I think that's just important in knowing about the anatomy and where it is and where it's going so that you can apply it to the rest of the joints. And then we'll go down to the PIP with a smaller footprint transducer. So this being the most common transducer people have, I'll start with that. This is our L15-4, and I'll start just dorsally, transversely. And I switched hands versus the rest of the videos just to give good camera window to the inside of the thumb. This is a little bit backwards from the rest of the shots. Just remember that radial is now screen right and ulnar is screen left. So I'm at the metacarpal here, and I can just scan that distally, 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 just to review. We've got the metacarpal, the extensor tendon, and as I go distal, you'll see the metacarpal change shape. So this little drop off that we have houses collateral ligament origins. And so we start there by going, actually, let's look at that long axis too. So I'll take this mid-sagittally, then I'll fall off radially so you can see that really neat, distinct shape. Remember dorsally, we had that nice metacarpal notch. And then that metacarpal notch, as we go more towards the thumb, will open up. And as it opens up, it becomes what looks like a lateral epicondyle of an elbow. And if you just think of it that way, then you can pivot the distal part of your probe inferiorly towards the table a little bit and down towards the proximal phalanx. And we get this nice elongated primary collateral ligament. There we go. So that's the primary, or as you saw in the anatomy diagram on the slides, think of it as the posterior of the two. So it's a P for primary. And then we have an accessory collateral ligament, which dives straight down all the way to the pulley system. I'll open up the thumb here just to give me a little bit more scan angle. And there you can see the shadow of the accessory right here, diving towards the table. So primary on top, accessory on the bottom, and this is on the radial aspect, but we have a nice long axis of an accessory collateral ligament of the MCP joint, and it will not insert so much on the proximal phalanx as it does wrap around to the pulley. So we'll hold the hand up here in kind of a karate chop position, and then we'll follow that accessory all the way around. So we're just looking at these nice long axis fibers here, long axis fibers, long axis fibers. We see we're still on the metacarpal. I'll start to see cartilage, articular hyaline cartilage on the volar surface, but you can see how that accessory collateral ligament here turns into a volar plate, just like that. So now we are looking at a volar plate. So when you're on the palm and you're kind of wondering where volar plates come from, flexor tendon, superficialis and profundus, and on flexor tendon number 2, underneath it, we see palmar plate. So let's follow that palmar plate radially, and you can just see that relationship. Same group of fibers wraps around and becomes the accessory collateral. Now from the rest of the palmar plate here, if I go distally, distally, distally to the proximal phalanx where the palmar plate is also originating from, just that front lip or the proximal lip. And it's better to practice on this knuckle because it's the biggest to see this relationship. When you get down to the PIPs and DIPs, I would more or less just look for the same landmarks, just with fluid collections or anechoic gaps. But you can see the same thing here. So you can see primary collateral superficially, and then you can rotate your transducer. I think it helps to just completely rotate the probe to go find a palmar plate and then work your way backwards on a PIP joint. Don't waste a bunch of time on the beginning of that epicondyle looking surface. It looks like an elbow there, right where the arrow is. So I'll go more shallow if it'll let me. Might even zoom in. There's our primary right there, that long axis ligament there. And this is where I think it's a good opportunity to switch over to our ultra high frequency 46 to 20. Same thing here. We're looking at that kind of epicondyle looking surface on the lateral MCP joint, following those fibers, windshield wipering the distal part of the probe right there. Now, to tighten these ligaments up, both sets really, making a fist actually helps. So let's curl the fingers and make a fist. And the reason that tightens it up is because the distal metacarpal head is shaped like a cam. So it's not perfectly round. The bottom or palmar side is longer than the front side. And so when we do that, this proximal phalanx wraps itself around the longer side of that distal metacarpal head, tightening these ligaments. So it is a way to put some stress on the footprint. But here we can see a really, really nice primary collateral. And if I go a bit more volar, we'll see the shadow show itself here of the accessory. And the accessory is in short axis in this particular case. So I would just rotate the transducer and point it down towards the palm. And then we can follow the primary collateral shadow, basically at this point, all the way down to the palmar plate. Now let's go down to PIP, collateral. Take a look at it. Same scanning technique, looking for that drop off, there we go, really nice. Maybe I just got lucky. Popped it right on there, too shallow. There we go, somewhere in the middle there. So we see the same thing. We see actual fibers because of the resolution of this transducer, but we can see these ligament fibers of the primary. And we'll rotate the probe almost in a complete short axis to see the accessory. So left side of the screen would be dorsal there. And there I can see the shadow starting to form of accessory right there. But the accessory origin being here up top. And this would be the primary going cross-sectionally across the joint. But we can follow these long axis fibers all the way to the palm, extend the finger, and then trace those down to its volar plate. So we can see the volar plate of the PIP there and those fibers that reach around. Okay, now let's go to the thumb UCL, which I think most people are interested in. Now, a few ways to get at this is just to understand how ulnar we're talking when we're talking about ulnar collateral ligament. We're not just talking about slightly ulnar to dorsal. It's extremely coronal, this slice that we're going to take. And remember, the aponeurosis is coming from the adductor pollicis from the palm, coming right under my gel there to the top of the knuckle and seeing it drape across the top. So to see that joint in a true coronal, you don't want to scan at this angle. You really need to take the probe and lay it against the second MCP joint. So I'm going to lay this whole transducer against the second MCP joint and drop it straight onto the knuckle. And that is the extreme coronal plane I want you to take when you try this. And then you end up seeing that nice ligament come up more shallow here. Same, looking for the epicondyle looking surface, kind of like we did on the elbow, right up here. And seeing it bridge that gap. Now it does help to kind of bolster the thumb. So we're going to put this bottle of gel under here. And this provides us a better scanning window and a more dynamic room for me to fully stress this thumb. So here I am, again, leaning this side of the transducer against the knuckle of the second MCP joint. When I drop it on there and then just set it right down in long axis to the rest of the thumb, really, I can stress the joint itself here just by putting my other finger behind it. And then my thumb is here. And that provides a nice fulcrum. So that tests the ligament itself. And you always want to do a bilateral study on this because you're always going to get the joint to open a little bit more than you think it should open. Okay. And then that ligament looks good. And then the other thing that we're going to test is the aponeurosis. And the aponeurosis, which is harder to see on conventional transducers, is this one thin black line right here. And anything in MSK ultrasound, you should make it move. So what we're going to do to make that move, we know that the aponeurosis is connected to the EPL, the extensor pollicis longus as well. So we're going to twitch the thumb distally here. And you can see me pull on that. And you get two, if you put your fingers in this position here, I've got the ability to twitch the thumb here and to stress the thumb this way, all in one scanning plane. So here I've got stress on the thumb and then up and down with the DIP to check the integrity of the aponeurosis. So stress, check. Now let's change to the ultra high frequency. Same scanning window here, extreme angle, much smaller transducer. So we're going to see a much bigger field of view, but now we see that really, really nice joint. Now we can see the fibers and really elongate them and focus on getting a true cut on the joint instead of just relying on horizontally based shadows. But there I'm stressing the joint the same way I did before. And then let's take a look at that aponeurosis that sits up top. And it's going to be this distinct line here, right there. I'm going to twitch the thumb. Let's get it going. And we want to make sure that that aponeurosis that's gliding, drop my arrow down just a touch more since it's just me in here. There. That aponeurosis needs to stay on top of the ligament. If the ligament tears and protrudes through the aponeurosis, you've got yourself a real Stenner's lesion. If the ligament tears and stays underneath the aponeurosis and the aponeurosis is intact, then you're just dealing with an isolated ulnar collateral ligament tear. And that's how you would classify the two. To see the accessory in this case is very difficult. It's not impossible. So there it is. The accessory is here, and it's going to look like a supraspinatus in the shoulder. And it's taking that extreme dive towards the, I would say, normal volar plate of the first digit, but it's going to go up to the sesamoid. So we should see the radial side, or sorry, the ulnar side sesamoid right there. and then that sesamoid gets encapsulated basically by the same ligamentous structures. And on the other side too, we have an ulnar sesamoid. But that would be the accessory collateral of the thumb. And then we would windshield wiper the other side of the probe over to the primary collateral to do that assessment.
Now we've got the flexor tendons and the pulleys of the fingers. It's a very exciting and dynamic part of the hand exam, but also very complex and complicated. Let's talk about the deeper layers. I'm assuming that you studied the palmar or the volar hand webinar. So I want to go over this relationship. After we leave the palm of the hand and we head towards the fingers, how complex and complicated the anatomy can get for something like the superficialis portion of the flexor tendon. So this is the flexor digitorum superficialis. After the MCP joint level, it will bifurcate, and then it will come on to attach at the middle portion of the middle phalanx down the sides here. Now, as it bifurcates, as it splits, there is a web that's very variable. So don't take the grid pattern that you see here as all of them will show this representation. You probably won't ever see these fibers unless you're using ultra high frequency. And then even then you're never going to see a standard layer here. There's about 8 variations of this woven pattern, but it's important surgically, I guess, if you need to see where the vinculum and the little neurovascular structures, basically the arteries that pierce and feed the flexor tendons, travel through this network here, and it's called Camper's chiasma. And I think of campers as, you know, if you're going camping, this looks like a hammock that sits across the two heads as they divide, and we'll see that in the live scan. They also hold the flexor digitorum profundus. So you can see the deep part, or the profundus portion of flexor digitorum comes out from between the split of the flexor digitorum superficialis and keeps headed over the PIP and then over the DIP to insert at the base of the distal phalanx. And that web here between the two heads holds that profundus into place. So we have the pulley system holding the tendons to the fingers. If you were to bend the fingers without this pulley system, the tendons would just bowstring across. And we're not going to go into all the pathologies. We just don't have time in the short amount of time that we have. But I will cover the survey of the hand and how to find these things and how to evaluate them. So we have the A1, the A2. That's anatomically very consistent. You can have anatomical variation from here on. It's not always going to look like this, especially if you go check out the surgical anatomy atlases. So if you get frustrated not finding the pulleys exactly after A2, the way you see on this diagram, just know that there's a lot of variation. A pulley, annular, means little ring. It's easy to see, it's thicker, and it's more structural. Cruciate, these are the C pulleys, C1, 2, 3, that means cross. And it's harder to see, thinner and less structural. Most people actually skip looking at these, and we would probably skip looking at them in the live demo, but use this as a reference. And then as we look at those in cross section at the level of A1, we see flexor digitorum superficialis, about a 50-50 split over flexor digitorum profundus. As you travel down to A2, you start to see the superficialis will split. And then as you get distally closer towards the PIP, just before the PIP, this flexor digitorum superficialis is split completely. And you can see that over here in the representation. This over here, these images were taken with our L19 transducer, the small footprint linear 19 megahertz. It's not the larger footprint L15 that I'll be using in the live demo. And it's not the ultra high frequency. That's not the ultra high frequency 46 to 20. So it's kind of our in between, but a lower frequency than ultra high frequency, but it images very nice. And you can see the pulleys very nice here. As we go more distally at the level of A3, we've got profundus now completely between superficialis. Superficialis is split on both sides. And as we head down to A4, where the insertion starts to attach at middle phalanx here, you can see the superficialis is now underneath profundus completely. And then as you go distally between the A4 and the A5, the insertion's completely taken place and profundus is out there on its own. Distally to A5, just profundus, and then at the enthesis at the base of the distal phalanx is just profundus. On the volar part of the first MCP joint, we have some varying anatomy here for pulleys of the thumb. The A1 pulley is very similar to looking at the rest of the hand, except it's going to bridge a gap between two sesamoids. We have an ulnar sesamoid and a radial sesamoid. And the ulnar side sesamoid is towards the palm. The radial side sesamoid is toward the outside of the thumb. And you're going to bridge the gap between those two, tilt rock your probe until you get this big dark umbrella. That whole web is basically a large network of pulley combined with the collateral ligament anatomy. As you go distally, this is where it varies a little bit. We've got a Y or oblique ligament. It changes names. It's not A2. So we had A1 here. This is A2 is up here. This is the oblique or the Y-shaped pulley because it does come off the adductor aponeurosis as well. Now distally at the level of the palmar plate, we can see A2, more traditional, looks just like the other pulleys did, except we don't see a split in a flexor tendon anymore. It's just flexor pollicis longus. So it looks a little bit different than the flexor, the profundus layer of the flexor digitorum.
So we're going to isolate the second, third, fourth, and fifth. So I'll start with the A1 pulley here on the MCP joint side of the hand. Dry skin is full of air cells, and air is the enemy of ultrasound. So if you've ever seen an abdominal ultrasound where gas gets in the way or lung sliding, you see what air can do to an ultrasound beam. Keep that in mind at the skin level, just like you're doing the heel and the foot. For plantar fascia, you want this type of skin here to be as moisturized and debrided of any callus or anything before you get started, just to give yourself the best shot you can. First, let's identify the bones. I like to stay in the third. I'll tell you why. When I'm teaching this or showing somebody, if you stay on the third, it keeps the bone relatively in a straight line. Whereas if I'm on the second or the fifth, the bones kind of take a curve this way, and the tendons definitely take a curve this way. So on the right side of the screen, we've got the proximal phalanx, and we have the distal metacarpal, approximately on the left. I'm going to bring my depth up more shallow to optimize. And we already covered a bit of flexor tendons in a previous webinar, so I'm going to ignore the hand part of the flexor tendons, but we are going to go into the part of the finger where the tendon kind of changes shape. So let's focus on the tendon really quick before we get into the pulleys. On the long axis of the tendons, we've got a superficial and a deep or profundus layer. And on some transducers, it may be a little less obvious. So what you can do is just isolate the DIP and cause profundus to move while superficial stays stationary. Now what you'll notice is as I go distal, profundus becomes more superficial. And then you see the superficialis portion of the flexor here dive on the sides, and that's more evident in a cross section. But here you can see them almost switch places, especially on the lateral edges of the tendon, like this. I'll go cross-sectionally, and let's watch them kind of switch places like we did in the PowerPoint slide. So when I'm proximal, I've got two layers of the tendon, kind of a hemisphere, profundus, superficialis. Superficialis at this point will split vertically, and we start to see the two heads of superficialis go on each side of profundus. Profundus changes its echo texture here because it's changing direction. It also changes its echo unless I were to rock the transducer. So if I rock the transducer to match it, they start to look the same. But if you let the anisotropic property show you which is which, you can leave the profundus layer dark and the superficialis layer will stay bright. And the superficialis layer are these triangles on the side as we reach the PIP joint here. So we have cartilage of the proximal and middle phalanx. So this will be the distal head, and then this will be the proximal surface of the middle phalanx. And we see up top what looks like three tendons. But what we really have is superficialis, superficialis, and profundus. What's not commonly on a lot of anatomy diagrams is that there are two heads to the profundus. You will see it on most of the surgical stuff, but not just general drawings. But there's a septum right there, and it stays there all the way to the enthesis. Here. If you're looking to differentiate between superficialis and profundus, at the level of the PIP joint, they've completely swapped places. So superficialis are these little triangular corners on each side of profundus, and profundus is in the middle and it has a septum. Now let's go back to the pulleys. So I'm at the MCP joint level here because I see cartilage and palmar plate, and I'm in the palm here. So we have metacarpal head with cartilage, proximal phalanx with no cartilage and no palmar plate. So this is palmar plate here. Then we have the flexor tendons, and then we have the shadows of the A1 pulley. So the shadows of the A1 pulley look a lot like kind of pigtails off the side of a head. So you see what looks like a head here, and then you see shadows which looks like hair. And it's a very prominent, broad, ligamentous portion. So if you wanted to get maximum echoes back to the probe, you'd have to dig in the probe to one side of the palm here, and those fibers would echo back. But when you just have the probe at a natural rest on the skin, it will just dive away, causing those big shadows on the side. So this is A2 pull or A1 pulley, which is thicker, more broad. And as I jump the joint gap and make my way to the proximal phalanx, we've got A2. So A2 begins right here. And if I go long axis on these, you can see that they're pretty far apart from each other in their shadows. So superficially, I have a shadow of A1, and A2 starts way down here, this broad kind of sock shape of a pulley down here. So A1, and if that shadow is not so distinct to you, what you can do is just move the finger to see the undersurface and rock the subcutaneous fat with the probe to see the superficial surface of the pulley. Right there. So we can see the fat rolling over the pulley. And at the PIP level, we have A3 right over the palmar plate. So A3 starts here. So we have palmar plate, and then we have the A3. We're going to ignore, basically ignore C1 because it's really hard to see. Most of the time you don't see it. In a conventional frequency, you probably won't. So you'll just jump from A2 to A3. A3 is right over palmar plate of the PIP. And then we'll keep on going over the shaft of the middle phalanx. And over the shaft of the middle phalanx, we get A4. So here we are over the shaft of the middle phalanx. We should get a bright white hyperechoic thin band right on over the shaft. That's your A4. And then up here we have A5, another bright white connective tissue layer right there between the arrow and the X. And again, if you're confused as to what tissue is what, move the phalanx, rock the fat under the skin, and make it move. Also easier to see in transverse. So I'll switch over to the ultra high frequency really quick. Left side of the screen will be ulnar in this case. I'll try to keep that conventional. And we'll go with bony landmarks here. So I've got a deep bone, turn the gain up just a touch there. So I've got a deep bone and it has cartilage right there. And that would be my distal metacarpal head. And then that tells me that I'm at the level where the flexor profundus on the bottom and the superficialis haven't quite split yet. And if I were to go distal to that, you would see that split right there. Looks a bit like a Mercedes-Benz sign. So we have superficialis, superficialis, and profundus. I'll bring my depth up more shallow so the machine focuses more clearly on that layer. And now we can see the relationship of the superficialis curling under the profundus as we go distal to the PIP level. See, it's already split apart from each other and curled under, and they almost join. They join with the fibrous band of connective tissue called Camper's chiasma or chiasm. And that's what is hanging on to a little bit of arterial supply to feed the flexor tendons. Okay, so now we're at the PIP level because I can see cartilage. I can see palmar plate. Okay, I see that septum between profundus. So this is all profundus. Keep that in mind. And if you want to get a really good look at the superficialis, you have to go almost like you're in a hemisphere, like I talked about earlier. So my arrow is on superficialis as it curls under profundus. So this is palmar plate. This is superficialis here. This is profundus. We can follow profundus up and over to the other superficialis, which is this other little corner. And then let's follow a superficialis to its termination or enthesis right here. There. You can actually see it inserting right there. There's this big long ridge on the middle phalanx that goes down the shaft of the middle part of the middle phalanx. And that big ridge, which can often be mistaken for a step-off deformity or a fracture, is just a long tubercle for the insertion of the superficialis. So let's watch that, and then we'll spin on it and go long axis. There we go, there. And I'll just spin the transducer, long axis. See how off to the side I am? So if I were mid sagittal to the finger, I get profundus, and it's 2 layers. And I can twitch the distal phalanx. But if I go off to the side, I can see this diving tendon very distinct away from profundus, and I can wiggle the tip of the finger and isolate that and show that that's not the profundus that we're looking at. It's strictly superficialis right there. So here I was over some profundus. Look at that. And then I go even more ulnar to separate the two. So superficialis, profundus, superficialis, profundus. So make it move, use your dynamic maneuvers. Then we'll take this second to talk about the palmar plate. So the palmar plate is this fibrous connective tissue that originates here at the base of the proximal or middle phalanx. We're looking at a cross-sectional plate of fibers. So the fibers are coming at us in the picture. And then they have a tail right here of fibers that branches off and holds itself down to the proximal phalanx right here. And these are called check rein, like the reins of a horse, check rein ligaments. And we can see one shadow here attaching to palmar plate. And then that Camper's chiasma that we were talking about is the rest of the connective tissue above that and below the flexor tendons, which acts like a hammock, bridging the gap between superficialis and profundus right here. So cross-sectionally, here's the PIP cartilage, volar plate, palmar plate. I'm gonna go proximal to that. We can see the shadows of the check reins. And then between the check reins, we have this hammock shape right here. That's not part of the flexor tendons. Doesn't move with the flexor tendon. It's a hammock. I think of Camper's chiasma as like a camping hammock. So this is like a hammock bridging the gap between superficialis, and then there's this connective tissue, like the dorsal part of the hand at the DIP had that triangular ligament bridging that gap over the joint. We have a lot of that kind of similar architecture here, and that's where we see Camper's chiasma, and it does hold some arterial supply to the flexor tendons. Going back to the pulleys though, check that out. Long axis pulley. There's just no doubt that we're seeing the undersurface of A1 right there. So arrow here, A1. A1 really starts with that palmar fascia way back here, but by ultrasound, we're definitely seeing the beginning of that structural A1 pulley right here. So dynamic maneuvers to do is to flex the tendon here, and then rock the transducer to get that sub-Q fat to roll over the pulley to help you delineate the margins of the pulley. So hopefully that helps you. So we'll go distal to that, and we'll look for the beginning of A2, which is this big, long fiber across the superficial margin of that superficialis. And it's shaped a bit like an airplane wing in that one side's really, really broad. And there's more of a connective tissue thickening at the distal part of A2, and that's why it looks much thicker. And it kind of teardrops on back proximally to a thinner margin, which I would say stops here because I can rock the sub-Q fat, and that sub-Q fat kind of goes down in towards the tendon at that point. So just use those methods when you're identifying the pulleys. Flex the tendon to see the undersurface, okay, right there. And then rock the sub-Q fat to see the top surface. And then you just keep following that. So there's A3, that hyperechoic triangle here. So flex, rock, move on down the line. A4, we're going to flex, rock here. And I'm not completely ignoring the cruciates, the C1, 2, and 3s, but they're just less a part of the exam than the annular pulleys. So I have a little bit of air under my transducer. There we go. So you can see the A5 really, really nice right here. So again, we can flex or we can rock. Actually, that was fat. So the pulley is under that right there.
All right, and that does it for the live demo. If you have any questions, go ahead and pass them in the portal. Chris, do we have any questions queued up?
Not currently, but just a reminder, if you're on the Zoom broadcast, the Q&A box is on the bottom or the side of your screen. So go ahead and put your questions into there. And then if you are on the LinkedIn or YouTube stream, go ahead and put your questions in the chat, and I'll make sure those get over to Daniel.
Perfect. Thank you, Chris. And that was a lot of content. So just know that that was a trimmed down version of quite a bit that was already previously filmed, and that if you're a member of the Sonosite Learning Institute, by being a customer, you will have access to a more long form version of some of the scanning techniques and the tips and tricks that it takes to catch some of these scanning windows. And if you didn't catch our previous webinars on the hand, we did cover the dorsal hand, and then we went to the volar hand. And then we had a guest speaker, Dr. Dan Malone, rheumatologist, over 20 years, musculoskeletal ultrasound expert, who was our guest here in the studio to do the arthritic hand, where we covered MCPs, we covered some arthritic conditions that involve the base of the thumb. We talked a little bit about gout, injection techniques. And then here to cap everything off, the advanced hand was more or less to finish off where the others ended, but I would say the more advanced things are out here in the fingers, where the anatomy gets smaller and a bit more involved. So your sports injuries typically being on the thumb, your climbing injuries, for example, being on the fingers and the pulley mechanisms. There's just a lot of intricate anatomy there.
We do have a question that just came in. What is the orientation of the needle when doing thumb A1 pulley injection?
So a thumb A1 pulley. So we will have a procedure series later next year, basically where we go over injections. We'll have guest speakers, guest physicians in that case, on how much of a medication to include, volumes. But if you were to do, which I don't believe our live scan, we really got a chance to stick with let's switch hands. Let me go to the other hand here. That way.
Just an FYI, it looks like you're still on the video and not on your live camera.
I see. Good point, Chris. There we go. There's the switch. Okay. So in general, that's typically done out of plane anyways, but you're going to find your sesamoids as a landmark. Everybody has the ulnar and a radial sesamoid there. And the pulley is bridging the gap on each side of that. So if you don't have the bones on both sides, you're probably not perpendicular to the pulley. Let me see how this looks on Zoom. I'm going to turn my gain up just a touch. There we go. But you would start with your needle out of plane, shallow, avoiding the sides. Probably want to land a center mark down the middle of the screen, avoiding neurovascular structures. So always wanting to put the color down first before you go in with any procedures. So you have nerves on each side, arteries. There we go. So marking your vessels, going right down the middle, parking your needle under the shadow, right where the arrow is. And then you would rotate your transducer, confirming you're not beveled down in a tendon, staying above the tendon. But here's our A1 pulley right here. Looks like a little airplane wing. And just confirm dynamically your layers also before you land your needle anywhere. But yeah, stopping your needle anywhere underneath that pulley where the arrow is and above the moving tendon. A little test shot might get you into the sheath, which is an isolated sheath that goes down into the carpal tunnel. But out of plane, right under there, center line, avoid your neurovascular structures. Whether you go proximal distal or distal to proximal, I would think going distal to proximal would keep you out of the neurovascular structures easier than going proximal to distal, where they have more room to rest over the tendon. Great question. We'll make a note of it when we have our guest speaker lineup.
Is there anything that you could go over that maybe you cut out of the video that might be quick to show?
You know, we did not get a chance to go in depth on the nerves, and I do plan on having a follow-up session on nerves. So I would say just the scanning technique involving small tubular structures like nerves is pretty much always the same. So I'm down here on the radius. I'm going to scoot our model into the camera. There we go. Here's our extensor tendon compartments. I'm over 2. This is 1. And we have that superficial radial nerve here. So the nerve anatomy as you go distal from here is it's extremely variable. But right back here proximal to compartment 1, it's usually pretty uniform. So you just pick a branch and you go proximal distal, and then you go down a little further. Then you pick a branch, just the same scanning technique, back, forth, back, forth, back, forth. Pick a branch. There, they just popped over that compartment 1, and now they're headed over on top of compartment 2. These are useful structures to map out. If you're doing something like a simple de Quervain's tenosynovitis injection, you might want to avoid hitting the superficial sensory branches of the radial nerve right here. So that's EPL right there sitting over the snuff box. So we can have our model just twitch her thumb, and we can see EPL activate. Nice. A little too much gain on zoom now. There we go. But yeah, that's her EPL, and you can see all those little nerve branches sitting on top right there. You could easily land your needle on accident into one of these little nerve branches and just cause some unnecessary pain, and you know, maybe artificially anesthetize an area on accident for a period of time that you didn't mean to. And then you got your radial artery here. A lot of landmarks in the area to avoid. But yeah, just scanning nerves. We'll have to have some requests if anybody wants to send us a list of nerves that they would like studied. The plan was to do the dorsal ulnar on the ulnar side to cover deep motor and superficial, and on the radial side, these radial branches of the superficial sensory. But we just ran out of time. There's only so much that we could fit in about an hour, but we plan on holding more of these webinars. We'll take your suggestions. That'd be great. But now that we've pretty much wrapped up most of the body parts in MSK on the webinar series behind the scan at sonosite.com, as Chris mentioned, under education webinars, or if you're a Learning Institute member as a customer and you have access to a lot more content, you'll see more of our learning modules be populated with more thorough explanations of each of these structures.
Yeah, Daniel's correct there. Let me get the link up here on the screen here. So if you go ahead and scan that QR code here, you'll be able to go straight to our webinars page there. But as Daniel said, I do believe that we are out of time for today. So Daniel, thank you so much for this incredibly in-depth hand series. I know it was a lot of work for you, and I think it was really amazing. So thanks for taking the time to get everything put together for us.
Thanks again, everybody, for joining. Thank you, Chris.